all, and my respect to the dignitaries and chairpersons.
Can you load your slides?
Sir.
Can you load his slides?
Media team, back team.
Dr. Mohanty.
Yeah.
For Dr. Mohanty.
Okay. My topic is hypertension among rural women with type 2 diabetes mellitus, prevalence, risk factors, and management outcomes. As you all know, hypertension and type 2 diabetes mellitus affect over 1 billion and 500 million worldwide as per the WHO data 2021. In India, the burden of non-communicable disease is growing. Mostly in rural women, it remains under-researched due to the vulnerable group. As per the ISMR India data 2020, the rural women face barriers like low awareness, socioeconomic constraints, and limited to access to care. My objective is to determine the prevalence of the hypertension among rural women with type 2 diabetes, analyzing the risk factors, obesity, glycemic control, treatment adherence, assess the outcomes after integrated pharmacological and lifestyle intervention. The literature overview, hypertension and type 2 diabetes leads to major cardiovascular risk. It's coexist since long. The rural Indian women are understudied due to the delayed health seeking, the low health literacy, the gender related barriers, the dependence on family for care decisions, and poor access to the specialist services. The need of culturally tailored and low cost care intervention must be affordable, community based, and adapted to local culture, including the nutrition guidance, the medication support, and the involvement of community health workers to improve the blood pressure and the glycemic control sustainability. As per the recent updates, the NFH data shows to approximately 44% diabetic women are hypertensive, henceforth the highly coincidence. The recent update ADA 2025 data shows stricter BP goal of 130 by 80 mmHg for people with diabetes, supports early and intensified control. The IDF 2025 focus more on community-based programs with health workers and tailored diet, improve BP and HbA1c sustain in rural India. The quality of life impact. Recent rural stories shows poor mental and social health among women with dual hypertension and type 2 diabetes. Insulin resistance and hyperinsulinemia leads to the sympathetic nervous system stimulation that leads to increase in the heart rate as well as the vascular tone, which increases the hypertension. All we know the endothelial dysfunction, the sodium retention by kidney, the artificial stiffness of vascular remodeling, activation of RAS, low grade inflammation and oxidative stress, all in leads to hypertension. This is the mechanism and this is the graph. So my method is community based cross sectional study in Odisha from January to August 2025 and also as a part of RSSDI 10 by 10 BP challenge in 2025, around 500 rural people with type 2 diabetes recruited from health camps and clinics. The clinical BP measured by WHO steps, the 3 steps method, the BMI, the waist circumference and HbA1c also taken. The structured interview of socio-demographic awareness and adherence was done. 3-month follow-up for hypertensive women after integrated management. We exclude the patient with previous history of chronic kidney disease, pregnant women, previous history of MI, chronic alcoholic and smokers. So our prevalence, hypertension prevalence come 42.4%, that is around 212% from 500 are hypertensive. The higher is the women with 50 years of age having 64% chances of prevalence, with BMI greater than 27 kg per meter square having 58%. The poor glycemic control HbA1c greater than 8 having 61% chances of hypertension. This is the structured interview regarding the barrier to the hypertension management, while the financial limitation, distance to healthcare facility, lack of dietary guidance, low awareness BP control, poor treatment adherence, the percentages are given here. So after the proper pharmacological treatment with proper OAD and insulin therapy, the nutritional counseling at least twice monthly, and the lifestyle advice delivered to 10 community healthcare twice monthly. We follow up after 3 months. there is a marked improvement in the baseline of the systolic blood pressure, that is from 158 to 136, the mean diastolic blood pressure from 94 to 82, and the achievement of the HbA1c level less than 7% improved from 21% to 48%. This is the graph before and after. This is the risk factor comparison after age 50, after BMI with more than 27, more central obesity, poor HbA1c, all leads to hypertension. So the hypertension prevalence 42.4% rural India, matching with the national trend, that is 30 to 50%. Poor glycemic control more frequently in hypertension women increase the vascular risk. The adherence gap is only 28% took the medication constantly versus the 50 to 60% in urban areas. So nearly half of the rural diabetic women in the study are coexisting hypertension with obesity, poor glycemic control, and low adherence to key determinants. Management requires not only pharmacotherapy but culturally tailored education, community support, and strengthening the rural health system. The resource-sensitive integrated strategies are essential to reduce the dual burden of diabetes and hypertension in rural women. So, as Dr. Bansi sir said about to add something about the history of diabetes, here the history of diabetes since 1550 BC, from Sushruta their Madhumeha to Langerhans discovering of insulin in 1921 to advances of synthetic insulin and their landmark study, Wikipedia study. I will acknowledge the community health workers, RSS Day 10 by 10 BP Challenge campaign, my co-author Tanya Agarwal and Bansi sir and Rutul sir for this opportunity. And these are the few pictures of my, and thank you all.